Dear colleagues, I am Dr. Keyur Parikh, Senior Cardiologist at CIMS Hospital, Ahmedabad. This is a case of an elderly gentleman who had a severely calcified ostial-circumflex artery, for which we did a combination of rotablator and angiosculpt balloon. Prognosis of left main coronary artery is largely affected by selection of the treatment strategy, and in presence of calcific ostial disease in left circumflex and in left antedescending artery, use of rotablator to debulk has had very promising results. People have also used cutting balloons in these ostial lesions. Rotablator system involves diamond tip bar designed to preferentially ablate and remove calcium and fibrous plaques. There is a console, foot pedal, regulator tank and various attachments. Among the disposable or consumable equipment is the advancer, the catheter bar and wire clips with specialized guide wires. Percutaneous rotational angioplasty with rotablator system as a sole therapy or with adjunctive balloon angioplasty is now indicated in these patients, mainly with ostial calcified lesions, bifurcation lesions, and it also minimizes side branch occlusion. Rotational atherectomy or rotablator, or now easily available orbital atherectomy, is used to break the tight block in coronary artery due to calcium deposition, where there is significant calcium. And recent studies at a TCT 2018 shows that use of rotablator in preparing this lesion creates much better artery opening and expansion. Many times asymmetrical stent expansion occurs where calcium is not properly treated. Calcium can preclude optimal stenting. With DES, rotational atherectomy is now an important tool for calcified lesions. Same TCT recent data in San Diego showed high-speed rotational atherectomy improved the success of stenting in severely calcified lesion in a study done in Germany. Atherectomy with rotablator achieved 98% successful stent delivery, leaving less than 20% lesion and excellent flow compared with only 80% with just modified balloon strategy. This is a 76-year-old gentleman who was having dyspnea on exertional nocturnal angina as well as effort angina with normal LV function with normal vital signs. Angiographic report showed right radial artery showed 90% ostial left circumflex lesion right at the bifurcation of left main into LAD and circumflex. He was advised for bypass surgery at an outside center or angioplasty high risk using rotablation. In rotational atherectomy, tip of rotablator device is made up of small piece of diamond coated bar which acts as a micro drilling machine. Its size is 1.25 to 2.5 millimeter. It rotates very fast inside the block and breaks the calcium into tiny particles that can safely pass through the bloodstream and be filtered out. To the rotational atherectomy, we lock the advancer knob 2 to 3 cm forward before advancing the bar into guide wire. Finally, controlling the wire, we advance the bar with the to and fro packing motion of the bar. When bar is proximal to the lesion, relieve any forward tension by unlocking the advancer knob and pulling back. As you see here, Rotalink causes plaque modification and debulking, facilitating further interventional procedure. Techniques of rotablation. You have to start a saline drip, you have to rotate the bulb, advance with free movement, wire is visible and brake is functioning. This is autopsy report in patient showing how angioplasty results in significant vessel injury, whereas with rotablators or orbital atherectomy a very minimal vessel injury with smooth circumferential lumen. Once rotablator ablates the calcified particles into small particles, size of the microparticles are less than 5 microns, smaller than red blood cells, which are picked up by the reticular endothelial system and removed from the body eventually. With ablation of plaque burden, less pressure is required for balloon expansion and shifting of the plaque in side branch is minimized. I'm in the cath lab right now doing a live case showing how the case. Here we are advancing the system into the coronary arteries. Now we are doing an angiographic which shows ostial origin of the circumflex artery with 90% occlusion. And we have started crossing the lesion with the wire and we are preparing the rotablator. As you see, the movement has to be precise, the entire positioning is precise, and while we are doing it, we do angiographic check. We look at the monitor, we look at the burr. You can now see the burr coming out. Now the burr is activated and at a RPM of around 175,000 per minute, we are advancing the burr across the lesion. You are seeing an animation and a real live recorded movement of the burr. The burr has now jumped after debulking the lesion into the main circumflex artery. The burring noise also can change when it encounters resistance. So in this patient, we first did rotablator, followed by using angiosculp balloon. After the rotablator, pre-dilatation was done using 2.5 by 10 mm angiosculp cutting balloon. After the combination, there was still under expansion of the balloon by fluoroscopy due to possibility of substantial fibrocalcific plaque. Having debulked the lesion, we decided to use an angiosculp balloon, which is a specialized balloon which is able to cut the plaques. By using pre-dilation with this specialized angiosculp balloon in past, the data has shown increased greater luminal gain and ended up with a much better stent area. You can see the video of the angiosculp balloon like you saw earlier of the rotablator, and there are very fine metallic wires across the balloon which helps in cutting the lesion. By using this, the dissection rate is much less and much better opening of the lesion is achieved using the angiosculp balloon. Again, as you can see, the opening is more symmetrical and better. A specialized guide liner catheter was used to ease the delivery of the calcific angle in the circumflex artery. The guide liner or guidezilla catheters are mother and child like catheters, where there is a catheter in a catheter, which has been used here, as you can see, and ease of delivery has been achieved of the stent across the circumflex lesion. Stent has been adequately expanded now, and post stent you can see widely open circumflex artery. Post dilatation was done across left main and ostium of the circumflex. Stent was placed across LAD into the from circumflex into the LAD. So my take home message will be rotational atherectomy or orbital atherectomy is a useful adjunctive device in interventional treatment of heavily calcified lesions. Rotational atherectomy allowed for substantial plaque modification that enabled successful balloon pre-dilatation. In this case, an angiosculp balloon was used to supplement, which gave even more optimal treatment without plaque shift, minimizing vessel wall stretch, eliminating vessel barotrauma, producing a smooth lumen channel, shortening procedure time, and reducing overall procedures. So finally, a properly performed rotational atherectomy followed by DAS implantation translates into excellent results, and latest data do confirm the feasibility of using rotablator or orbital atherectomy into such cases, and additional use of various cutting balloons, in this case the angiosculp balloon, assisted in even much better opening.